Okay, I think we will continue with the next session. This is a session supported by the World Federation for Interventional Stroke Treatment. And Dr. Anna Podlasek, you're the first speaker, and you're going to talk about WIST accredited training, operator and team training. How is it done?
Thank you so much for the introduction, and I want to pass a huge thank you to Professor Petrov for having us the next year, the consecutive year, and for ongoing collaboration, and having us again in Sofia. So, with the World Federation for Interventional Stroke Treatment, the mission is simple: for people to understand that the stroke, it's a brain resuscitation. It's a sudden problem that needs to be dealt immediately, because otherwise the patient will have a very bad outcome. It was with the words of the Professor Nijankowski from Poland, who highlighted the time pressure of this life-saving treatment. And there has been quite a few guidelines so far showing how we can train doctors to perform those procedures. However, they were not inclusive. They very often were based on the time-based approach, where the doctor should be placed for 2 years in the center. But it's difficult to take a break from your life for the whole 2 years to focus solely on this training. And already Dr. Vasilev, with the first presentation of the session, he mentioned about the expert opinion, what is really needed for the other specialties to get trained. And that was the overlying thought behind the World Federation for Interventional Stroke Treatment guidelines that are much more inclusive. And what's different with them from the other one? It is that it highlights the importance of the competency. So it doesn't really matter how long does your training take. As long as you can safely perform procedures, you are good to go. It also allowed not only practicing on the patient, but also using high-fidelity simulation and the unique perfused human cadavers model to get not only the operator skilled in the procedures, but also take the whole team on board. Training is in fact only one part of the WIST process. It starts with the simple telephone call, with the interest of the people wanting to set up the service. We then go out and visit the hospital. We get to know what's currently there, what are the people who are involved, what is the infrastructure, and we help to set up all the standard operating procedures. Then once all of this is set up and there is a support from the hospital administrators, we start the training to teach them how to perform quickly and safely this procedure. And it doesn't end with the training. There is ongoing support, ongoing proctoring and monitoring that there are no problems. And what is this training? It has two main parts. The first one is the clinical knowledge. It starts with the assessment of the patient, even before the hospital. How do we select patients with the high probability of large vessel occlusion? What is really the NHSS? And we don't expect everyone to do NHSS in 30 seconds as our stroke physicians. But for all of us to have the understanding what NHSS of 3 or NHSS of 12 or 28, what does it mean to the patient and to the workflow? This is what we are trying to have the whole team on board to speak the same language. And as it has been mentioned multiple times today, the imaging is the key for predicting how the patient could benefit from the procedure. And we know that already on the example of the Hungarian Dr. Sikora lecture, that it can really change how much quicker and how many more patients are having access to the treatment. That's why we're teaching not the interpretation, but how to use the information guide taken from the images into the pathway. And most importantly, we are teaching how to collect all of this information quickly, because when the stroke happens, we don't have half an hour for a nice chat with the T to understand what's going with the patient. We have to have the structured convey of the information to be able to quickly arrange the whole procedure. And on the other hand, we are also focused on the procedural training. We are doing it in a two-way. One is the high fidelity simulator, where we can upload our own real cases and real patients that we've encountered in the hospital and train with the device in a calm environment, being able to repeat certain steps if they were difficult. And once this setup is known and everyone is very familiar with all the steps of the procedure, we go on to the perfused human tail cadaveric model, which is unique because it gives you the opportunity to train on the real human anatomy with the real devices. You can see that there's also, a big focus on the setup. You can see or recognize all the balls, all the flash systems and devices, even how to open, how to flash. It's all part of trying how to do those things. And with the simulator, not only you can repeat the same procedure 5 times or 10 times or how many times you want to be sure that you're going smoothly and quickly, but also we can train the complications. So what happens if the vessel ruptures? What I really like on the simulator is that there's on and off buttons, so you can switch them off and on, whatever you want, an easy mode or not, which makes life much more easier. And this is a quick video, because what also can be done, and this was a little bit alluded that we are having this ongoing support. So what we can see, it's not only the simulator in this example, but also the rod and cones glasses that could be used for the remote proctoring. So once in the newly set up center, the person is doing the procedure. On the other hand, we can have a look exactly at what they are seeing on the screens, or in a minute, what they are able to see, what they are doing with the hands. And there could be, we are beyond WhatsApp, that's what I would say. And for the next picture, we'll just ask not to take any further pictures. So this is a model that Steph will tell us much more detailed in a few minutes about how it's set up. But what it gives in the training opportunities is that we are working with the real devices. So exactly what you will have on the table with the real patients, you can have before to have the practice with it. And we do put a huge impact on flushing because 1 milliliters of air in the brain can cause huge problems. And this is very crucial for any neuro procedures. That's why we train all the tributes first. We are also making sure that the flush is ongoing, and also the pressure bag. We really liked, in the live case today, there was a new setup that we saw that you can put 2 bags into 1 pressure bag, and this is a new setup that we are thinking about stealing because the idea is great. And why this is so important? Because if we stop flushing, then the thrombus is forming inside of the catheter, and then this can be in the patient's brain. So that's why we are also introducing a new safety device, which is just a simple clip-on device on the line, and it monitors, is there a flow or not? And if the flow stops, it alerts. Because if you have urgent situation, 3-5 lines, sometimes it could be missed. And once we are all happy with the procedural steps with opening the vessels, we are still teaching how we take care of patients after. Do they need ICU? Do they need HDU? What's the blood pressure target that they need? And even with all of this theoretical and practical knowledge, we mandate continuous audit about the times, about the outcomes, to make sure that the operators in the center are safe. All of this is also discussed in much more details during the ICA conference, for which we invite you cordially in June. And if any questions, we're ready for them.
Anna, thank you very much. Very informative lecture about the different ways because of the fullness. Or are there any questions from the audience?